Good afternoon, ladies and gentlemen. Thank you for coming to the Bioturium Seminar Series. We're very happy to today actually introduce Dr. Leah Siskind. We're very honored to have her here and visiting us and giving us this very interesting presentation. So Dr. Siskind actually has a Ph.D. degree, not an M.D., but a Ph.D. degree in biology with a focus on biophysics from the University of Maryland. And then she did postgraduate studies at the University of South Carolina. And then she came to UofL in 2013, where she's been residing in the Department of Pharmacology and Toxicology. But she's also associated with the Cancer Center in the medical school. She's the Director of Graduate Studies and the Associate Vice Chair for Graduate Education, among many other things. So she's very busy, has done great work, and she's here to talk to us about this here. So I will pass this to you.
Okay, so thanks for having me. So, is there a feedback? Or? Yeah? Is it me? No. Where the feedback is coming from? Oh, I think it's an alarm.
Oh, yes. Yes, there's a siren going.
Okay. All right. So hopefully it won't annoy you guys too much. Okay, so this is the building I work in. I normally, when I give seminars elsewhere, I always like to show the building that my lab's in to kind of show people this pretty building and that Louisville's a real place, and people often don't believe me that are, you know, in the big cities. And so if you haven't been over in the clinical and translational research building, I hope sometime you get a chance to come by and check it out and see what's going on over there. So I run a laboratory with another scientist, Dr. Leah Beverly. We co-direct this laboratory that we've coined the Tumorigenesis and Therapeutic Outcomes Laboratory. And the idea of this approach to cancer biology is to approach the problem from multifaceted direction. So we try and not just come up with novel therapeutics, but we try and improve current therapeutics and think about long-term outcomes for patients. So it's not just how are we going to get rid of the tumor, but how are we going to do it in a way that doesn't make that patient's quality of life not worth even living after they've survived cancer. And we approach this way by trying to look at the models that we use and see how those models that we use to come up with cancer therapeutics or therapeutics to protect off-target toxicities, how they recapitulate the human disease. Because we were getting frustrated because the cancer field is often looked at by other fields as this big success story for having 9% of drugs that are successful in phase 1 and 2 trials make it to patients. So they think 9% is a great success rate. And we actually look at that as a 91% failure rate. Clinical trials cost billions of dollars a year, and why are things that are so promising failing at such a high frequency? Part of my research involves acute kidney injury caused by chemotherapy, and the failure rate in that field is 100%. So we don't have a single drug, and we've been researching this for 30 years. So we look at different models, not just using cellular models where people traditionally have cultured things on 2D on plastics, so we're using more of a 3D approach of culturing cells directly from patient tumors that we obtain in the clinic under hypoxic conditions that recapitulate the tumor, to doing things in mouse models that may be doing regimens that more closely recapitulate that of the human treatment, and advancing to other models such as the pig, and I'll tell you a little bit about that later, that are closer to human. So I'm going to tell you a little piece of this story, and that's a story that is really close to my heart, and that's of chemotherapy-induced nephrotoxicity. And so I'm going to go over what that is and why you should care about it, what the current models that were used for 30 years are for chemotherapy-induced nephrotoxicity, why that they potentially are a reason for the failure of drugs in the clinic, how we went on to then address that, meet with the oncologists to develop a brand new model that showed us a completely different pathology, and that we incorporated the comorbidities of what occurs in the clinic, and that actually changed the model themselves. I'll show you a therapeutic that we are working on. I can't really tell you exactly what it is because we're trying to push it through with a patent. And then we'll show you the beginning of our pig models of cancer and standard of care chemotherapy. So first of all, what is acute kidney injury? Acute kidney injury differs from chronic kidney disease and many other kidney diseases in that it's an abrupt loss of kidney function. So it occurs in a matter of hours to days to maybe a week. And it's measured by two things in the clinic, serum creatinine and blood urea nitrogen. And you need to keep in mind that these are really bad measures of kidney function. Neither one of these markers changes unless there is a more than 50% loss in your nephrons, which is the functional unit in the kidney. And so they're measuring things like urine output and serum creatinine bun as a marker of injury, and that is a very blunt measure. So we really don't have good markers yet. But nephrologists use something called the rifle criteria when they're addressing stages of acute kidney injury. And this stands for risk, injury, failure, loss of function, end-stage renal disease. And what I want you to focus on is that injury is classified as a doubling of your serum creatinine, which is 50% loss in kidney function. So patients that get kidney injury, this graph is basically just showing you the worse the initial injury is. So the worse that increase is from serum creatinine, the less the survival is. So I have a collaborator that does drug discovery and over at the Cancer Center, and when I showed him this, he was very alarmed because he had kidney injury resulting from antibiotic, and his serum creatinine went from 0.1 all the way up to 11, and he was on dialysis. And so if you look at the survival rate, that's about 50% for someone like him, so he's lucky to be alive. And again, there are no treatments for this. All they can do is supportive care. Kidney injury is typically classified into three types. Those that are pre-renal, so those tend to be things upstream of the kidney that decrease blood flow to the kidney. Things that are post-renal, so that would be something that prevented urine output, like a kidney stone, and those that are intrinsic, those that directly damage the kidney. And those can be divided into many different causes. You will have, for example, when there is an earthquake, a major earthquake, there are nephrologists that go with the World Health Organization to these locations because you think somebody's crushed under a building and getting them out is going to save their life. But actually, when you relieve that thing that's crushing their lower extremities, what results is a kidney injury because the skeletal muscle releases, it's damaged, it releases toxins to the kidney that cause something called rhabdomyolysis. Football players get this as well. In really hot weather, when they're doing preseason training and they're not getting enough fluids and they damage skeletal muscle, they'll also get rhabdomyolysis. So these are direct things that damage the kidney as a result to damage to another organ that releases toxins. But chemical nephrotoxicity accounts for 20% of all these cases, and that results from drugs. Medications that are given to people that have a side effect of nephrotoxicity. And cisplatin is one of the major ones. And why do we care about cisplatin? Well, it's used in 20% of all cancer patients still today. It's a mainstream chemotherapeutic. It was approved in 1978, and it took the survival rates of testicular cancer from 10% before 1978 to 85% once it was widely used in these patients. So it is still an extremely effective chemotherapeutic. And even with the new immunotherapies that are coming out today, they're not used as single agents, they're combined with cisplatin. So it's still a mainstream drug for those that are able to actually be put on this drug. These are some of the cancers that it's used in. So it tends to be more solid tumors. And it's got typical side effects: nausea, hair loss, diarrhea, dehydration, ototoxicity, but the main one that actually limits its use in the clinic is the nephrotoxicity, meaning kidney toxicity. The levels that they use it at in the clinic are aimed to prevent the kidney toxicity. But it still occurs, even at those levels, and even with taking patients that have these pre-existing conditions of obesity or diabetic nephropathy or prior insults from other causes of AKI. These people cannot be on cisplatin. They put them on a less nephrotoxic chemotherapeutic like carboplatin, but that's often not as good at treating the cancer, or they would have been put on that to begin with. So even with all that, it still causes acute kidney injury in 30% of patients, along with these other major used drugs to treat cancer. So our thought is, and that of other people in the field of nephrotoxicity, is that if we could prevent that, we could actually use it at the level that's better at reducing tumor burden. And if we could prevent that, we could improve long-term outcomes in patients. So what happens when a cancer patient has acute kidney injury? Well, like I said, there's no treatments. And so they're either taken off the chemotherapy, they delay the next dose of the chemotherapy, or reduce that dose. And all three of those options, even if you switch them to carboplatin, that's less nephrotoxicity, all of those options are not good for treating the cancer. So our idea was that, the other issue is that patients, because AKI is so hard to diagnose, and I told you it's a very blunt measurement, we were thinking that the rates of chronic kidney disease in patients that get cisplatin, so pediatric patients, the rates of chronic kidney disease in these patients are very high, 2 to 3 years after they are done with treatment. So if we could treat it, even in people that don't show AKI, maybe we could prevent the chronic kidney disease. So ideally, we would give something prophylactically with the patients that wouldn't impact the ability of cisplatin to reduce tumor burden, but would protect the kidney, and maybe even some other of the side effects. And so, again, the NIDDK at the NIH has been really pursuing this for over 30 years. And the main issue, there was a meeting recently, and the main focus of that meeting is why is everything failing in clinical trials? And they came up with 3 reasons. 1, the design of the clinical trials could be flawed to begin with. 2, we don't have any biopsies from humans, so we have no way of knowing what's actually going on in the kidney. And 3, maybe our models in rodents don't at all recapitulate that of a human. And so that was my main thrust, was that our models don't recapitulate the human. Because if you look at the models that have been used for 30 years, basically the current model is let's give 1 high dose of cisplatin to a mouse that's 8 weeks old and male, and the mouse is going to die after a few days. So at day 4, they're going to die. But we're going to analyze them at day 3, where 100% of those mice in that group have kidney injury, and severe kidney injury. Mainly that cisplatin is causing apoptosis and necrosis in the kidney, and the mice aren't aged. 85% of people that have cancer are over the age of 55. These are very young mice, and they're all male, and they don't have cancer. Only people with cancer get cisplatin. So we teamed up with some of the oncologists that treat lung cancer, non-small cell lung cancer, and we thought, okay, let's give it at several low doses like they do in patients, and periodically give low doses that don't cause overt changes in serum creatinine, so that we can look at the long-term effects, what's going on in the biology of the kidney immediately, and then long-term following. And again, we don't know what that biology is, and then let's incorporate some of these comorbidities and see how do they actually impact the disease. So we developed this new model. This is work done by a recent graduate from my laboratory, C.R. Sharp. And so our new model was multiple rounds of chemo that's given in the clinic. So patients get it once every 3 weeks. Sometimes it's once a week. It depends on the type of cancer that they have. And then we were going to eventually factor in these comorbidities. So what the model we developed was once a week for 4 weeks, and then look at the mice 3 days after the last dose. And we compared that to the old model. So I'm going to show you some of this data, and then I'm going to show you how we've incorporated the comorbidities and how we've then gone beyond mice. So the old model, you get this overt change in your blood urea nitrogen and serum creatinine, and you don't really see that much of a change in this new model. And so we're thinking maybe this recapitulates the 70%, or even in those 30%, those that don't go on to kidney failure and don't need dialysis. There's been some new markers that have been developed in the urine that are now starting to be used in the clinic. One of them is something called NGAL, one is KIM1, so we looked in the urine for these markers. They're really overtly elevated in this old single high dose model, and they are elevated but not that extremely in this new model. When we looked at in the kidney for inflammatory cytokine and chemokine levels, We didn't find that many differences between the old and the new model. So both showed large elevations in the expression of these chemokines and cytokines. The main difference that we found was with IL-6. You get this huge increase in the old model, and you still get an increase, it's just not as great. Cell stress markers, this is where most of the things in clinical trials were developed towards hitting apoptosis and ER stress. Again, old model, you get really good markers by Western analysis of kidney homogeny, of ER stress, and of apoptosis, and we do see ER stress in the new model, but we don't see markers of apoptosis. We've looked using other methods, and we just aren't finding them. So at this point, we were a little discouraged, and we sent our slides to our trusty renal pathologist at the University of Arkansas to do the pathology. And just like we expected, nothing surprising here. There was a lot of necrosis in that single high-dose model. I mean, the mice are literally dying in 4 days, so you're not surprised. There's a lot of necrotic cell death going on, a lot of other things, pathology. But what did surprise us was this part here. So in the old model, there wasn't a lot of immune cell infiltration, despite the fact that we had the inflammatory cytokines and chemokines, but there was in the new model. And we had major interstitial fibrosis. And for those of you that don't know, fibrosis is really the hallmark of chronic kidney disease, and it's thought in many organs to be irreversible, although that dogma is starting to be changed. So because of that, we thought, maybe there's a completely different pathology going on, and maybe that's why some of these things targeting apoptosis or necrosis have failed in clinical trials. So we went to characterize this further, and you're looking at a cross-section of the kidney. For those of you that aren't colorblind, my lab just happens to have 2 out of 8 people that are colorblind, so this is a hard stain to do, where it's red and green. The red indicates collagen staining, and the green is just staining all the cells. And so when you get a robust increase in this red, that means it's staining all the collagen in the kidney. And so you can see after 4 doses, there's a large amount of collagen. You don't see this after a single dose of cisplatin. So if you look at like just 1 dose of 7 mg per kg, we did look at that, and there really isn't. We see a lot of fibronectin in this model, and other markers of fibrosis like TGF-beta, phosphosmat3, and some of these other markers that are typically seen in chronic kidney disease. In fibrosis in the kidney, there's a cell type that the field still doesn't know the origin of. It's called a myofibroblast, and it will proliferate, and that is the cell type that is secreting all these extracellular matrix proteins. And the stain for that is alpha smooth muscle actin. And you can see here we have a lot of alpha SMA positive cells in the kidney cortex. So we thought, do we have a true model of chronic kidney disease, or do we just have a model of fibrosis? Because chronic kidney disease has some other markers. It's got endothelial dysfunction, there's glomerular associated pathologies, chronic inflammation that persists, and progressive injury. And so our goal was, if we're going to really identify things to affect long-term outcomes, we need to look long-term. And so that's what we did. We decided to further characterize the model by looking after the 2nd dose in the model, immediately after the 4th dose, as I showed you before, and comparing that to mice that after 4 doses are then aged out for 6 months. And so we refer to those dose 2, dose 4, and 6-month age out. So you can see here the BUN is, the blood urea nitrogen is persistently elevated, so even though we haven't injured the mouse in 6 months, it's elevated. Our NGAL, which is a marker of injury, it's elevated after dose 2 and 4, but as expected, it's now back down at dose 6, so the injury that was occurring is gone, so you should see it back down. But our fibrosis is not. Our fibrosis is even elevated even more. One of the things that was similar in those 2 models was inflammation. So we wanted to look, does inflammation persist here? And so we looked at a ton of inflammatory cytokines and chemokines. I'm just showing you the 2 most interesting ones here, which was TNF-alpha and IL-6. And while it's up after dose 4, it stays up 6 months later. And IL-6, which was up, is even higher. It's now 20-fold elevated at 6 months later. So these things are persisting. The thing about IL-6 that's a little tricky is that sometimes it plays a role in acute inflammation, Sometimes people have implicated it if it goes up and stays up, it plays more of a role in fibrotic signaling. So again, we don't know exactly what this means or what cell types is even producing it. But we do know that elevated IL-6 persistently has been linked to macrophages. So what you're looking at here is something where we've stained for macrophages. F480 is a marker of macrophages. So this brown staining that you see here is staining positive for the macrophages. So at dose 4, we see a lot of macrophages, and so it's even further increased at 6 months later. So they're staying there, and there's even more of them. Macrophages have many subtypes. I'm grossly simplifying this for you here, but there's an M1 subtype and an M2 subtype. Most of the time you have a little bit of both or a hybrid phenotype. The kidney, though, never has arginase 1 expression, so when it does, we know it's from an M2 macrophage, which is nice, as opposed to other organs that have it all the time. And you can see we don't get anything too profound with an M1 phenotype, but we do get increased M2 phenotype that is still elevated, albeit not as much 6 months later. M2 macrophages are thought to be anti-inflammatory. They're supposed to repair injury, but once they repair the injury, they're supposed to go away. So what we think is going on is that they aren't able to repair the injury and they're persisting, and that's been implicated in fibrosis in other organs. We looked at that same collagen staining, and we got really dramatic staining. It was beautiful, where we've got collagen surrounding the tubules and in between the tubules here that is much higher than at the 4-week mark. The dose 4 mark. Our alpha smooth mast cell actin fibroblasts are already they're all beautiful, which is what I think, and they are actually persisting into the medulla. So this brown staining is these myofibroblasts I was telling you about that are making all these matrix proteins. So, we've done a lot more than I'm showing you here, but I'm going to summarize and skip some of the other data just so I can get to some more interesting stuff, or what I think is more interesting. And that is, immediately after this dosing regimen, we see, markers of injury like NGAL, and that is FDA approved. We do see inflammation. We do see M2 phenotype for the macrophages. Interstitial fibrosis has already developed, and all the profibrotic growth factors are there. And we do see severe endothelial cell dysfunction. Most of this persists. The NGAL is no longer there, though, because the injury's gone. So while the injury's gone, the damage has continued to get worse. So it's almost like a scab that's formed that the body still thinks needs to be more and more and more of this scab, is what I'm comparing this to. Persistent inflammation of the M2 F480 positive macrophage phenotype. We get glomerular pathology, so we start to get a glomerular sclerosis-like phenotype, and our endothelial dysfunction persists. So, to conclude this part, this injury that occurs can progress to CKD. And that we need to be a little bit concerned, I believe, in not just the patients that get a spike in serum creatinine and their treatment regimen has to be changed. We need to be concerned about our pediatric patients especially, that at 8 years old have no business getting chronic kidney disease. One can argue in a 70-year-old, maybe they would have gotten it anyway. Is that really linked to the cisplatin? We don't know. But we know in our pediatric patients that it shouldn't be occurring. And so we need to be worried about the patients that don't show overt markers of injury and what's going to happen long term to them. So here I've showed you where I've compared the standard model and our repeating model to that of the patients. And I've gone through and changed our dosing regimen. But what I haven't done is change the comorbidities. This is mimicking more of a pediatric patient, albeit we still don't have cancer in there. And so we wanted to do this in a model where we could look at the effect of aging and cancer together. And so what we do, this is the portion that we're focused on now, is where we look at aging and cancer. And again, 85% of our patients that get cancer are over the age of 55. So what model do we use? We're a lab that studies lung cancer because lung cancer, we have the #1 rates of lung cancer and lung cancer-related deaths in Kentucky in the entire nation. It's the #1 killer of cancer nationwide, more than the next 3 causes combined. So our lab does study lung cancer. We look at a model of lung cancer that's dependent upon something called an oncogene called KRAS that is mutated in a lot of cancers, but it's mutated in a significant number of lung cancers. And it's a model where it occurs as the mice age. And so you've got two transgenes here. The second transgene in this mouse expresses a human mutant active KRAS, and it's under a TET-O promoter, okay? This is only active when this RTTA is being produced, which is under control of a promoter specific for the cells that line the lung. And it only gets turned on in the presence of doxycycline. Okay, so mice that have to have two transgenes, transgene 1 and transgene 2, that when put on doxycycline allow for the production of this mutant active form of KRAS in the lungs only. Our control mice are also on doxycycline, but they only have one transgene, so KRAS doesn't get turned on and they don't get cancer. So here we can image these mice in our animal facility. This is an MRI, and what you can do is you can look at, here's a vehicle, treated vehicle meaning just saline, they don't get cisplatin. You see the lung nodules, and 4 weeks later they appear to be worsened. Here is a mouse that got cisplatin, and you see these lung nodules, and they look like they might have improved a little bit. Take it with a grain of salt, because the imaging, again, mice breathe, and MRI is not that great for imaging lungs. What are the advantages of our cancer model? It seems a little bit counterintuitive why we'd use this. Well, we use it for a couple reasons. One, most people that do cancer models will try and do xenograft models, where they subcutaneously inject tumor or cancer cells underneath the skin of a mouse. The mice don't have an intact immune system. If they did, they would attack that cancer and get rid of it, because it's a foreign cell type. And then the mice are young, and so this model that we're using, we wanted the intact immune system, because in our model it looks like the immune system plays a role. Other labs have also showed that when you don't have an intact immune system, the mice are actually resistant to cisplatin-induced nephrotoxicity. So this allows us to look at lung cancer in the location it should be in, the lungs, not under the skin on the hip, with an intact immune system and as the mice are middle age or over. So we've got these mice that we're calling non-cancer and cancer. Non-cancer meaning single transgene, cancer double. And we treat them with our model, and then we look at them after day 24, 3 days after the last dose. And we got pretty surprising results, to the point where this is where a boss needs to be hit. I needed to be hit upside my head because I didn't believe the results and assumed my student had done something wrong, so I made her repeat it, and I was wrong. It was right. So this is an example of an experiment that Sierra did, and what she found surprisingly was the mice that had cancer had reduced survival. They couldn't handle the cisplatin. So we get mice without cancer or those that are without cancer that get cisplatin, have 100% survival. Here, we're getting less than 50% of our mice with cancer are able to actually survive the full dosing. Most of the death occurs between the second and third dose. And so what we did was we analyzed these mice, and what you're looking at here is the kidney function of the 25% that survived. So at the end of the experiment, no difference. That's not surprising. Those are the ones that could survive the treatment. NGAL was actually different. The cancer mice looked like that survived the treatment looked better. So what we did was we went back and redid the experiment, and Sierra would collect urine from the mice after the dosing, right before the next dose, because the mice were dying right before the third dose, mainly. And so she did it at day 6 and day 13, and you're looking at this urinary NGAL marker of injury. After day 6, the non-cancer mice didn't have any increase, whereas the cancer mice had a profound increase. At day 13, the same thing. The non-cancer mice didn't show injury, whereas the cancer mice had a profound increase. This is about a 28-fold difference. And you can see this is right before we get this big change in survival. And so our hypothesis is that this could be due to increased injury to the kidney. But again, this is still just a hypothesis, because we haven't proven that. One thing I do want to mention is there is a very big cancer biologist, Tyler Jacks, that is now showing in this same mouse model profound changes in the liver as a result directly of that oncogene KRAS in the lung, where it's changing something systemically that is actually changing the liver metabolism and affecting the circadian rhythms of the mouse. And so this is something that another graduate student is following up on that I will have to update you on another time. When we looked in the cancer mice, at the Sears red fast green staining earlier on, you can see that they're getting profound collagen deposition. They're starting to get myofibroblasts. They already have the TGF-beta and the fibronectin. So this again is agreeing with in support of our hypothesis that they could be dying because they have worse injury in the presence of this mutant KRAS than the age sex-matched control mice that only have the single transgene. So our data indicate our comorbidities are important components of this model. So then we went on and we had a drug that we've been working with, and the drug targets a receptor called the P2X7 receptor. And I'm going to shorten this story a little bit for you. And basically, this receptor is what is turned on in response to injury, and it's upstream of fibrosis. And we had done a bunch of data ourselves and other groups with this receptor, implicating it in other forms of chronic kidney disease and fibrosis. And we've never put it in a model with chemotherapeutics. And so we went on to say, okay, this P2X7 receptor, when inhibited in the old model, is protected. What about this new model? Because it's known to be upstream of inflammation. So I'm going to just tell you that I can't really tell you what the drug's name is that targets this receptor, other than we call it SIR, and we call the combination of SIR and cisplatin, Sirplatin. But what we did was the repeated dosing model where the mice were co-administered cisplatin or the vehicle, or cisplatin and ceramin. So they got, I just told you one of the names of these drugs. They got Sirplatin, essentially, is what we're causing this new formulation. And we looked at BUN, and we looked at serum creatinine, and we found that they were protected at the end of the experiment from both of these markers. And I'm just going to show you the most convincing data, and that is the survival curve. So the cancer mice went from having this 50% survival to now all being able to, except for one or two mice, be able to handle the treatment. So we improved the survival of the mice, and we've gone up to look at the fibrosis and whether the fibrosis is protected, and it is. And so now what we're doing is we're actually trying to give it after the cisplatin. So if you give cisplatin, cause the injury, let the injury develop, can we give it after that to reverse the fibrosis? And that is an experiment that when we get enough money we can do, because these mice cost a fortune. So we've done a lot more that we've got papers submitted on, but we found, just to give you some additional information if you're interested, that the time of day that the cisplatin is administered grossly impacts the biology. Liz Cash, who is at the Cancer Center, is giving a talk on this coming Wednesday, tomorrow, at a series called Beer with a Scientist over at Against the Grain. And her work is on how circadian rhythms affect the response to chemotherapeutics and how they can actually predict how advanced a cancer is. And so they look at circadian rhythms looking at glucocorticoids in the saliva, and they can predict better than the MRI whether the patient's cancer has advanced based on how far off their circadian rhythms are. So cancer can affect circadian rhythms. Circadian rhythms can then affect the response to treatment. And we find the same in this model. The mouse strain, again, impacts the response to cisplatin. That's really something that we have to take a bigger look at. We're finding that there's some data suggesting that microbiome may impact it, which may complicate this model too. So you can do we had 3 labs do the same exact experiment in the same exact way. 2 of those 3 labs, mine and another, got the exact same result. Another lab didn't. And so we're looking with the 3 labs as to whether this could be a difference in the microbiome between our facilities. And so the moral of the story is the way that we model something greatly impacts the biology that we get. And so, yet again, I don't know that we have the right biology, because the question is, what's going on in the human? That's really what's important, because here we created this model and we don't know what humans get. We've contacted every major O'Brien kidney center in the entire United States. There's not a single biopsy that is available to anybody, including myself, to be able to look at what's going on. And you ask why? Why are there no biopsies? And the reason for that is there's no benefit to the patient to do a biopsy. So for example, patients with lupus nephritis, you do a biopsy that dramatically impacts the course of treatment that those patients get, because there's many different types of lupus nephritis. Here, we get the biopsy, there's nothing different you do for the patient, and every time you do a biopsy on the kidney, you risk hitting a major vessel. So there's really no ethical reason that you can do it. Other countries, I think in China, they have some biopsies, and they do see glomerular sclerosis developing late stage, where they've done 3 biopsies. But again, 3, what does that tell you? In patients, you need a lot of data from a lot of patients. So mice differ greatly from humans. Humans are 3,000 times larger than a mouse. We live 30 to 50 times longer. We have 10 to the 5 more cell divisions going on than a mouse does. Mice develop cancers without even any genetic manipulations of age, and they're of mesenchymal origin. Humans have a bias towards more epithelial-based cancers. Mice metabolize drugs dramatically differently than a human, and our organ systems are very different. So that makes modeling things very difficult in a mouse. And so many different cancer models. This is just a table that I pulled, if you're interested, from the source, showing cancer models that are in a mouse lead to one type of cancer, whereas that same mutation in a human has a different phenotype. So, we teamed up with, our friend, Jeff Clark in our department, and, we were looking more at, what are the genetic differences in mouse cells versus human cells? Well, you can take mouse cells in culture and you can do one genetic manipulation, sometimes it requires 2, and you can immortalize those cells. Human cells require more hits to be immortalized and to be transformed. Human cells require 6 or more. And when you look at the biology of a tumor, you get 6 to 20 different major things mutated in a tumor. A mouse, the KRAS model we showed you, it was 1 to require that cancer to develop. So, the level of genetic differences are dramatic. And so we also hypothesized that that's why these phase 2 trials are failing. That's why drugs are failing, because the models we're using preclinically before people are doing these billion-dollar trials are in mice. And so what we then turn to is what's better than a mouse. And so our friend Jeff Clark was long convinced that the better model was a pig. And he actually has a grant to look at breast cancer model in a pig. It's called a Eureka grant. But the reason that pigs, we believe, are better is that they have longer lifespans, closer to humans. They live upwards or more longer than 30 years. They have a lot of genetic variability. So when you get pigs that are of a particular type, they're very different from one another. There's a lot of heterogeneity in that strain of pig, just like in humans. Their genome has been sequenced. There are genetic engineered pigs that are now available, and NIH actually has a pig consortium where if you can convince them that the pig you want to make, the transgenic pig, is useful to multiple groups, that they will actually pay and make it. Their organs are closer to ours. So the kidney is closer physiologically to a human than a non-human primate. Therapeutics, medical devices, I don't have to convince this group that are better than pigs. There's people, there's faculty in bioengineering that use pigs and cows because their size, their physiology is closer to that of a human. Their drug metabolism is very similar. Their body surface area, these things that you use to calculate, are better in pigs. And in pig cells, you need 6 or more hits, genetic mutations, to transform them, just like in humans. We think genetically they're more similar. So really, today, anything you do in a mouse, you can do to a pig. And people have acted on that. There's several models of pigs and cancer that are available. These are the ones that are currently available. Some of them are flawed. They develop a mesenchymal cancer versus an epithelial. But again, they're one hit of one mutation. And so what we did was, myself, Levi Beverly, Jeff Clark, we put our head together, and Leslie Sherwood, heads together, and we came up with a pig model of lung cancer. And this model, I'm going to tell you the general nature of it, where we have hit 4 or more different genes. 3 of them we used CRISPR-Cas9 that was given intratracheally to the pig. And the 4th was a carcinogen available that's present in cigarette smoke that is known to cause mutations in KRAS. And so we gave this to the pig several times, and then we've been monitoring these pigs by several different methods: MRI, PET CT and their blood chemistry panels, and we're about to take them down. And I'm going to show you an image of the imaging. So this is the actual CT, PET CT device that's in the cancer center. And this is the first pig that's ever been put into it. So this is this is a mini pig, believe it or not. That's not very mini, but they're pretty big, even the mini pigs are. And we've gotten a couple indications. We also have a liver cancer model we're developing where the pig has had altered liver enzymes, so we're about to probably euthanize that pig. And you can do anything to a pig that you can a human. So they have ports, and just like cancer patients, and we can give chemotherapeutics, and we can give the immune therapies. We've given them the immunotherapies that they're being put into the patients, IPI and EVO, to see if we can model those drugs in the pigs. And so we're also developing a standard of care model in the pigs, just like in the mice, where we're repeated dosing the pigs. We're in the process of getting this through the IACUC right now. And so this has been a really big project. It's a big collaboration between the 3 labs and Leslie Sherwood, who's the head of veterinarian in our facilities. And so for that, unfortunately, you're going to have to stay tuned to see what's going to happen, because we don't have any data yet. But I think that's really what's going to answer our question is, what is this mouse model really worth? And is it really a fibrotic phenotype? Even though everything indicates that, we really believe the pig is a better model preclinically, that people should, it works in a mouse, it works in the mammal. When you're getting things through to IND, you need 2 mammals. Well, we think that it should be put into a pig before it goes into human to save money. And pigs aren't that expensive. One of these pigs costs $600. I have knockout mice that have cost $250 a mouse. The housing's expensive. Housing is about $6 a day for a pig versus 5 mice in a cage for $1 a day. But a lot of research universities allow, once you get the pig developed, they can house it on a farm, and that housing can go down to $1 a day. So you're going to have to wait on that data, but hopefully we'll get something interesting. And with that, I need to acknowledge the people in my group that have done most of the work. And I had to move Sierra Sharp down here because she defended in May, but she is a former member now. And then Mark Dahl is another person in that group working on that. And then the rest of my former lab members and all of the Beverly and Clark labs and the Louisville Porker team, which is what we call ourselves, and then our funding that has allowed us to do this work. So with that, I'd like to take questions.